Okay, so thank you again for the invitation on this interesting topic. And I would like to focus a little bit more on where the limit is for anatomical shoulder arthroplasty in terms of retroversion of the glenoid. So I think we all know that the glenoid component is the limiting factor to the success of total shoulder arthroplasty. This is related to the technique. Surgical implantation is not always the easiest part. And also the mid and long-term survival are determined by the glenoids. Especially type B glenoids are challenging because there's only so much bone that you can correct or ream. The correction of the limited is by bone stock and also by subluxation. And therefore, we see, among others, that people are doing more and more reversed arthroplasties, even in patients with the primary osteoarthritis and an intact rotator cuff. Other possibilities than reverse arthroplasty, newer possibilities now are coming our way with augmented anatomical glenoid components, and I will talk about that a little bit later in the end of my presentation. I'm still a big fan of anatomical arthroplasty. I must say that's still my practice. This is 2019. This is the year before the Corona year. Is still about 70% reverse and about still 30% anatomical, and I still believe it has a very important place in my in my practice. But of course, the glenoid version of the correction of this is limited because by the bone stock, and there's been previous reports that the maximum correction done by eccentric reaming, which basically is reaming the high sides, is about 15 degrees. If you correct more, obviously you will end up with no bone stock at all, and this will have bad influence on the implant fixation, but also on the tension of the rotator cuff. On the other hand, as well, if we do this using standard instrumentation, if you look at our precision, it looks like we're not always that good as we think we are. This is a landmark paper from Dr. Ianotti's group in 2012, where they compared standard instrumentation with PSI instrumentation, and actually retroversion is not so reliable. Correction of retroversion is not so reliable using standard instrumentation, especially when the retroversion is more than 15 degrees. And this was the start for 3D planning and PSI, like the previous surgeon was alluding to. This is a patient that we all would agree is quite a challenge in terms of indication. He's a 52-year-old. He's clearly young. He has a primary osteoarthritis, but a deformed glenoid, a B3 glenoid. As you can see, the cuff is intact, and preferably you would do an anatomical replacement. But the question here is it actually possible? And if we look at the glenoid and the retroversion, for me, the 3D planner has really changed my way of looking at it, and has changed my practice quite a bit. I use the planning tool to virtually assess whether I can still correct some part of the retroversion without compromising too much bone stock and compromising my implant fixation, and trying to avoid PEG or cement perforation. And this is how I try to do my surgery in a virtual fashion. And if I think it's still doable, I will use PSI guides to actually execute that virtual plan. I have a guide that helps me to find the first central pin, and this is obviously going to determine the further preparation of the glenoid and the implantation of the glenoid component. And then I have a second reamer that helps me to exactly execute the eccentric reaming so that I can get the correction that I desired to get. And then finally, I'm still able to do this implantation of this anatomical glenoid component, and all cemented in this case. And this is that patient, and in the meanwhile, he had 2 of these type of surgeries done, a bilateral, and as you can see, this is 2 years after his surgery. He has an excellent result. I'm very happy with that. Anatomical replacement gives that sort of results if you do them well, and at least because he's still young, he has a future much longer than I think for a reverse arthroplasty. So using this technique, and this is my experience, 22 patients, we looked at these prospective study. We just published them in JSCS in seminars in arthroplasty, where we did this technique. And as you can see, the mean preoperative version was on an average 15 degrees. So I agree that if it's more than 20, 25, obviously there's a problem. And as you can see as well, the correction was on average -7 degrees. So we do not try to correct all the way to neutral. It does not make any sense to try to correct an anatomical glenoids to 0 degrees if that is this patient had a constitutional retroversion of 15 degrees, because that also will not work. So we try to find a sort of way in between. But we had very good outcome, both clinical as well as radiological outcome. The biggest concern, of course, is glenoid medialization. How much bone do you remove? And we found a clear linear correlation between the correction of the version and the medialization. And basically, we found that we, for 1 degree of correction, we would take away 0.8 millimeter of bone. And on average, in this study, that meant that we removed about 6 millimeters on the anterior side. This is another example of such a patient with a preoperative version of 16 degrees that we corrected to about 7.8 degrees. So not to neutral, but somewhere below 10 degrees. This is that result for this patient. Again, the digital planning and the virtual planning helps me to finally make the decision preoperatively. This is a patient, as you can see, where when we correct for the retroversion, we really need to medialize quite a bit. And in this case, I think this is 1 bridge too far. This is more than 10 millimeters of medialization. This is obviously not good for the implant fixation, and also not for the tension of the rotator cuff. And so therefore, probably this patient does better with a glenoids, with a reverse type of glenoid implantation. Again, here, we also want to correct the version using an augment, a posterior augment in this case, which leads to a nice correction of the retroversion in this type of surgery. For reverse, I think it's important to try to correct to 0 degrees. And here we have this final virtual result. So my personal algorithm for this problem is if I can correct the glenoid version to less than 10 degrees of retroversion with eccentric reaming and less than 80% posterior subluxation, my preferable technique is eccentric reaming and standard anatomical glenoid components. If it's not correctable to less than 10 degrees, but the posterior subluxation is still less than 80%, I will use an augmented anatomical glenoid component. And if that is not the case, whether it's not correctable to less than 10 degrees or the posterior subluxation is more than 80%, I will definitely use a reverse arthroplasty with or without bone graft or an augmented base plate. So please save the date for an interesting, hopefully live conference that we are organizing here in Antwerp next year in April, specifically focused on shoulder arthroplasty and innovation and new technology. Thank you very much.